work and what you do, and
Yep.
Some thoughts on pain, where we're going.
Yep.
So let's get this up here. Yeah. How was the move to Australia, Ben? First off.
Good, yeah. So I moved there in January, so I'm still very much finding my feet. So it's part of a postdoctoral fellowship. So I did my PhD in Ireland. My background is physiotherapy, and I was awarded a fellowship by the European Union to basically improve my development as a researcher. So I'm basically in Sydney on training and development purposes. We'll spend 2 years in the University of Sydney, then 3 months in Belgium, and I'm more in Brussels as part of a more communication and dissemination role, which I think you guys would be interested in. It's more how do you disseminate the findings of your fellowship or disseminate something that you find to be important on a more European level. So I think that'll be very good. That'll be for 3 months. Then I have 9 months back in Ireland, back to where I started, and then go from there.
I'm getting the feeling that subject is very that interests us a lot, because like you're saying, disseminating everything that we know. It's not for us; it's for the people who we
consumers,
help.
patients. Yeah,
Exactly. It seems like it's getting more and more to that point where we're talking about those.
And I think what I find is as the science progresses, so we're learning more and more about the complexity of pain and learning more and more about approaches, but still the real basic fundamental stuff that we know has yet to be communicated to society. So, it'll be very difficult for us to try and disseminate more complex aspects of pain until we can actually communicate the more basic things, whether it be about discs being out of place, whether it be about injury, bed rest, the basics of staying off work. So unless people start to understand those basic things, it could be very hard to,
I'm with you all the way.
Communicate about exactly, and chaos theory and
Oh,
multi-sensory environments. All of this really good and important stuff. It'd be very important, very hard to get that to be understood if people don't understand the real basic blocks.
What I'm thinking, it's a romantic thought I have, is when we get to the point, and I quoted you on this one because I love it, avoiding the pendulum arguments. Clearly, it's not all about the tissues, but it's not, but they are relevant as well.
Yeah.
But I'm wondering if we ever get to a point where, for example, I might be able to sit with a patient and talk about the back pain as we do with headaches, in the same way. We know it could be something else, but we're all in the understanding of a lot of stuff influences this.
Yeah.
I'm especially interested in back pain as well, because I had back pain. I know it as well. It's not funny, but it's also a lot not about the back, and it's really interesting. But I didn't have a question there.
No, I understand what you mean. That how can we get to the level of communicating risk of serious spinal pathology for back pain on a one-to-one level? So if we are communicating with somebody about headache or somebody with chest pain, people are more comfortable with the idea that it might not be serious. And I think that comes from maybe some form of shared decision-making tools that you can communicate the highly, that it's highly unlikely that someone will have serious pathology. And then actually learn to communicate with them about the risks of imaging. So you're trying to almost get them to weigh up the risks and benefits of going on to get more tests. But I think that's very hard for back pain at the moment, unless people have the basic information. But I know in my group at the moment, there are people looking at how do we communicate risk to patients with back pain. And that will come through probably decision aids. And just how do we explain the way serious spinal pathology is very rare, so what are the benefits really of going for all of this imaging that's more likely to lead to more overdiagnosis and more unnecessary treatment. But I think again that's something that it needs a bigger approach for people to actually understand the problem. It's very hard on a one-to-one level. If it would be like getting a doctor to try and convince somebody that they don't need antibiotics, but then the whole world is telling them that they need antibiotics. And it would be the same for a GP trying to get a patient to give up smoking, but there's no campaign or there's no wider approach to help that doctor or physio.
So how to avoid unnecessary Sisyphus work, kind of.
Yeah, exactly. Like yeah. But if you had a campaign on a wider level about imaging or about back pain, then it could be easier. It's like the smoking and the antibiotics, and they're difficult things. It's easier probably for the clinician to have that conversation without backfire with that patient.
What about pain interests you?
Is there something about pain in particular?
Yeah, exactly. We asked this question to Jason Silver, and he said nothing special. He's more interested in behavioral change, and pain is a part of the patients he seeks for.
Well, I guess I would have been somebody that I would have had some back pain as a teenager. Like, we know that pain is very prevalent as a teenager. I think what interests me is just that the way it can be driven by so many things, and that it isn't always related to injury and all of these things like cognition and stress and sleep and the way fatigue, all of these things, the way they can influence pain. That's what interests me, the way it's so like almost other health conditions like fatigue and depression. So I don't know, is there a very specific area of pain that really interests me, but it's more around the way you can have pain and the way it's a kind of a protective mechanism as opposed to it being all about injury. So that makes me interested in everything to do with pain, because there's so many factors involved. Absolutely. But it's, I guess the way it's just not simple is interesting.
Yeah, a hard problem to grapple with.
Yeah, exactly.
I'm jumping in the questions here, but this brings me, because I'm doing my master's and I'm trying to get to know all the science methodology. And one thing that interests me a lot when it comes to pain, and relates to the last question actually is, I mean, when we do studies, we have to base it on some type of meta theory, and our meta theory in physiotherapy is Helen Hislop's pathoanatomical models and stuff like this, and it turns out to be meta theoretically wrong at some level. Yeah. What is? Let's just talk about you. What theory in pain is your? Do you like the best? And you can use bias here. Mm-hmm. Where are you biased here? And
do you have a specific meta theory that you adhere to more than others?
Yeah.
Strengths,
I guess
limitations.
I guess during my PhD, I would have been looking into very different theories. You'd be looking at the fear avoidance model, you'd be looking at social cognitive theory, you'd be looking at more pain neurophysiology theory. I think I'm at the place now where I just look at different risk factors or prognostic factors and make them my theory. Yeah. So try and keep it broad. I really like that paper from Mick Thacker that talks about first-person neuroscience. Have you ever read that?
Yeah, no, I haven't read it, but
it's almost kind of saying that we need to move away from theories, and we were always trained to ask patients very specific questions so we could fit people into particular boxes, but that hasn't worked that much. I like the theories put forward by Louis Gifford.
And mature organism model.
Yeah, I really like that. Yeah. But again, that's if you look at what we talk about in our group and Peter O'Sullivan's work, I think a lot of that fits with the mature organism model. And I think a lot of these models, that they're almost trying to be separate, but lots of them are learning from each other. Yeah. And the danger sometimes is that we're almost trying to develop a new theory or trying to develop a new model, while realizing that there's probably good aspects to take from all of these models. And how do we look at a kind of a framework, a more framework with lots of different factors. So, because once you look at one theory,
a framework that fits complex phenomena.
Exactly.
That's what I understood from what you said, or correct me if I'm wrong here, but you look at how all the knowledge we have can be used for a specific person.
Yeah,
is
exactly.
That
yeah.
It sounds kind
and
of
it'll
sensible.
never be the same, but it's like we have the models, we know the range of factors that could be important, but then how do we find out, or how do we profile, I guess, a person? And even that probably sounds a bit reductionist, but trying to learn from all the different theories that have been out there and then I really like the Mick Thacker's work as well with the predictive processing stuff and the emergence, because that again fits with, look, there's so many factors here together interacting, and that it would be wrong to, reduce anybody to any one particular model. So I don't know, have I any particular system or model? I guess my PhD, which would have been looking at the role of cognitive functional therapy in low back pain, would be trying to take a multidimensional framework to treatment. But I see that as trying to integrate the knowledge that we have from different fields and trying to make a framework that you can be flexible with every individual. But you need some form of model, I guess, to guide you, because otherwise you don't know what is important to take from that first person narrative. But it's having the knowledge about what might be important, but then being flexible. So
not being zealous about one specific.
Exactly. Yeah.
Speaking about that, and if we think about movement-based approaches for back pain, maybe like Mackenzie or kinetic control or whatever.
Yeah.
What do you consider is, if you have thought about this, is the common denominator that makes them good or bad or useful or not so useful?
I would say what I like about all of the movement approaches is they're encouraging movement, at least. That's one thing I do like. So they're giving some form of a center modification procedure in favor of movement. What I don't like is the theory behind how they might work. So whether it be centralization or the disc moving here or the actual mechanism behind how they've been proposed to work. I wouldn't agree with how that has been explained in the past. But
why does that matter?
I think it matters because it could influence the mindset that the patient might have around the exercise or around movement or around pain. So if you go back to what we've spoken about in the last few days, if we know that all of these factors interact, how we think about the exercise affects how we might move and all of this. I think it's good that if the patient doesn't have a real pathoanatomical or biomechanical theory behind why an exercise might work, because we don't see the evidence showing us that we know how exercise particularly works. So I like movement-based approaches from the perspective that they get people moving. They're to some extent they're encouraging movement. I don't like sometimes that they can demonize certain movements. So some can be more anti-flexion or some can be more towards extension, and some of the theories behind them. But they have taught us, I guess. A lot of these approaches have told us that different approaches work differently for different patients. People respond differently to different approaches. So I like the individual nature of some of them, but just I guess some of the theory needs to be a bit more contemporary, I guess, if that makes sense.
Absolutely, and it gets me thinking about, regardless if it's movement or manual therapy or a combination of the two, that you can have a positive effect in the short term. And a lot of mechanisms could explain that.
Exactly.
But then there's the possibility that the same thing has a negative effect in the long term.
Yeah, and we're not sure at the moment, is that because of the treatment? So is it that the treatment is having a negative effect, or is it that the patients that go on to have the negative effect, we see that they're more likely to fail lots of different treatments.
Okay.
And I think that comes back to what we've been talking about in the last few days about the importance of knowing prognostic factors that are predictive of recovery. So I think manual therapy takes a good, criticizing. It gets really heavily criticized, but I'm more focused on, I guess, what is the message that you're giving with any of these approaches, whether it be manual therapy or the exercise. What is the patient's understanding or expectation, or what are they going away with? Because I think it's the extremes of these things. So manual therapy mightn't be the problem, but if you're giving someone excessive passive treatment for a long time and giving them the impression that they need you all the time, that might be an issue. But in the same time, like exercise, people really like exercise because it's something active. But if you're giving someone the impression that they need to do this one exercise because they need to strengthen their back and avoid other exercises, well then that impression isn't good either. But sometimes it can kind of get sold as, well, all manual therapy is bad and all exercise is good. It really depends on the message and what the patient is taking from your message, I think.
I have two kind of hard, maybe yes or no questions for you here. Would you be confident to say that you wouldn't be physically endangering yourself by any movement for the back? I didn't frame that one. Did you get that one?
Yeah, I think...
No. Would you be confident to say that you're fine to do any movement?
I think it depends on our definition of fine. I think it's like... I don't think any movement is inherently dangerous or permanently bad for your back. But I think it's also foolish to say...
Leaning on what we know about backs.
Yeah, but I think if somebody, a bit like a hamstring strain, if somebody, does maybe unaccustomed activity or does something that they're not used to doing, it's perfectly understandable to think that they might get an episode of pain. Or something will happen. It's very hard to say in the instance, are we talking here about pain or injury? Is it something that's, when it comes to protection, it can be hard to compare, let's say, a hamstring with the back. But I think I wouldn't give somebody the impression that, you can lift whatever way you want or you can bend whatever you want. None of that has any impact. Because we know if some unaccustomed activity or people that lift heavier loads or open postures, they're more at risk of developing an episode of acute low back pain. But it's more but that doesn't mean that they're damaging or really injuring their back.
So the word fine has to be split up into you can have more pain but not necessarily damage yourself.
Yeah.
And this can be causing some damage, but you can probably prepare yourself with some loading.
But if
strategies.
somebody really hurts their back, or let's say they strain their back if they're doing a deadlift or a squat or whatever they're doing, I think it would be foolish to say that they don't need to maybe rest and give themselves a chance.
Yeah.
I think we do that, like you would do with an ankle sprain or something like that. I guess the problem with the back that we're trying to say is people then tend to kind of demonize the particular activity that hurt them or give them pain when it's to do with the spine. But if it was the ankle, people are quicker to go back to the same activity. So I think that's where we want to avoid pendulums, but I think with the back, people just continue to be, I guess, black and white. Yeah, cautious of particular activities around the spine. So I think, there isn't need for black and white. I think if their pain is, really provoked by a certain movement after doing a particular activity, maybe we need to back for a while and give them time to settle, but then reintroduce and gradually, return them to whatever activity. It's very hard to get into, what's happening when the person gets the pain. Is it an injury like a hamstring strain, or is it the protective system just increasing because they haven't had that before? Yeah.
I love that. There's no yes or no.
Yeah, there isn't.
That's good.
Yeah, there isn't a yes or no. Yeah.
But what are the easiest things we can do to improve our managing of pain issues? It's a huge question, but what is the most easiest thing we can do? Get rid of this and things would be at least one step better. Yeah,
I think the idea that back pain always needs a firm diagnosis, I think that isn't just physios, I think that's the world in general, that back pain always needs to be something that's diagnosed. So how can we be a bit more, prudent with things like imaging and investigations and examinations? So that's the first thing. 2, not giving people beliefs of vulnerability around the spine. I would say that's probably the biggest thing, kind of telling people about you need to mind your back because it's bad to move, or things are coming out of place, or you need to rest. I think those basic things about bed rest, things coming out of place, staying off work, the real bigger message, they're the real things we need to get right. And then giving people an understanding that pain is an aspect of health and can be influenced by different things. But I think it needs to start with doing less harm. So the stuff around giving people real beliefs of vulnerability around the spine, and the stuff like the imaging. I think they're the big things.
So if we don't have all the answers how to do everything perfectly, we don't have the perfect recipe, even though that's the wrong term.
Yeah.
But
yeah.
we can do less of the things that are proven to be unhelpful. Is that
Yeah,
right?
because we definitely don't have all the answers. I guess what we do know, I think we know more about what doesn't help as opposed to what helps. You know, like a lot of the interventions we have, you know, small effects. But I think we're very aware of medication, imaging, all of that stuff being unhelpful or harmful, and the belief stuff. So if we can actually change some of that or just not contribute to it, I think that can be helpful alone. But then trying to find this really effective intervention for pain itself can also be difficult. But I think they're two things that can run together. You know? Yeah.
Okay.
Yeah.
Thank you.
Done. Okay. Thanks.
Thank you so much.
No problem. No problem.
I'll just pause this. Awesome.